This is Dr. Sakhnini speaking, welcoming you to this new video that discusses the acute repair of UCL thumb. So this is the ulnar collateral ligament. This is a 50 years old patient. As we see clinically that the joint open, we put a stress upon the ligament. The approach is straightforward with a curved incision on the ulnar side of the thumb, followed by gentle dissection of the soft tissue. Care should be taken not to injure the dorsal branch of the sensory nerve on the dorsum of the thumb. Following dissection of the soft tissue, the subcutis, we recognize the sensory branch and keep it safe dorsally with a retractor. Following this, we expose the adductor aponeurosis that is continuous with the extensor mechanism. At this stage, we cauterized any crossing vessels that may impede our dissection. As we can see here, this is the nerve that has been recognized and kept safe with a retractor. Now we can see the adductor aponeurosis and we open it. Aponeurosis connected with the extensor mechanism, so we elevate the extensor mechanism up in order to find the collateral ligament, the ulnar collateral ligament. What we are holding now, this is the ulnar collateral ligament come to view with the help of some irrigation. Now we assess the injury. As we assess it more, we can lever the joint and see that the ligament is completely torn off and avulsed with a small fragment. Now the small fragment leaves a hole in the base of the proximal phalanx that will help us put the anchor in this hole, in this place, in order to anatomically restore the origin of the collateral ligament. And to be exact, we utilize Y not 1.7 millimeter Conmed true shot anchor that we see here. It's a simple mechanism to use. We put it exactly at the point of avulsion. It needs 10 millimeter depth of K-wire advancement, and we can see here that we have a 2 fiber wire, 2 fiber wire sutures. Following this, we put a pin in the MP joint in order to protect our later repair. This is instead of putting a cast, so we will not put a cast. Eventually this pin will help us make sure that our repair that we are doing right now with the help of these 2 fiber wire sutures is safe, and we keep it for 3 weeks. Now we do the first row of suturing, of anchoring of the collateral ligament to its anatomical location, and we can augment it for more with the local soft tissue. It is up to the surgeon to choose the technique that he uses for reattachment, or even choosing the anchors, as there are multiple options. This specific anchor leaves no metallics in the phalanx. It's only a suture ball that is inside the phalanx. So at this stage we finished reattaching the UCL back to its anatomical location at the ulnar side of the base of the phalanx, and now we are closing the aponeurosis with the 2 limbs in order to further augment our repair and close the soft tissue. This will help the repair of this area. As we can see here, this is not a Stener lesion. Stener lesions leave the collateral ligament out of the adductor. In this case, we needed to open the adductor fully in order to expose and delineate the injury of the collateral ligament. So we meticulously close the adductor with the extensor mechanism in order to restore full function of the thumb later. Following this, we close the soft tissue in layers, subcutaneous and the skin, in this case with the help of the 4O Vicryl rapid suture. The pin that we put here, we take it out in office in 3 weeks in order to allow range of motion, and it is followed by occupational therapy. We start by exercising flexion extension, followed by opposition of the thumb, and at a later stage we work on the pinch and we restore power. So the patient will need some occupational therapy for a few weeks. A question could be asked about the nature of the surgical modality versus conservative treatment. This is an acute injury. I feel that the surgical choice in acute position get a predicted outcome. It's straightforward, easy to reattach the ligament. If the injury becomes chronic injury, it's not treated, or the ligament did not get back to its place, then we are talking about reconstruction with the help of a fiber tape or even a tendon autograft, so which will complicate the outcome and the surgery. So in this case, acute injury to the UCL that is treated with the help of anchor reattachment. We used a pin here to protect the repair. We utilize the fluoroscopic view in order to see that the joint is congruent, and we put the joint, the MP joint, in 30 degrees flexion, and then we did the repair later. And we will not be putting a cast on the finger, only a bandage. So I hope that you enjoyed this video, as it shows the simple technique for UCL repair. I hope that you enjoyed it, and I appreciate if you leave a comment.